الأول بس أرحب بحضراتكم. أنا خالد عبد الكريم، أستاذ الأورام في طب عين شمس. يعني سعيد بالحضور الكريم، ومش عايز أقول إنه يعني إن إحنا جلسات CNS من الجلسات الصعبة اللي دايما حضورها بيبقى مش كتير، لأن إحنا بنتكلم في حاجات very highly specific في الأونكولوجي وفيما يتعلق من تخصصات. بس أنا في غاية السعادة، ويعني مش عارف أقول إيه، إن أنا قدامي هذا البانل الرائع ودون ترتيب الأسماء. من الشمال لليمين أستاذ دكتور عمرو الشهابي، أستاذ جراحة المخ وأعصاب طب عين شمس. أستاذ دكتور خالد أبو الفتوح، أستاذ الأشعة التشخيصية وأحد خبراء النيورو راديولوجي من عين شمس. أستاذي وأخويا الكبير أستاذ دكتور أشرف بيه الأبيض، former or ex president of neurosurgery department عين شمس. دكتور محمود الليثي، أستاذ علاج الأورام بطب عين شمس. دكتورة هند العزازي، مدرستنا الشهيرة واللي شايلة اسم النيورو أونكولوجي في our department. and honored to have دكتورة أسماء صلاح إبراهيم. ميرسي جدا على تشريف حضرتك. أنقل الميكروفون للمنصة الكريمة لتقديم المحاضر الأول. اتفضلوا يا فندم.
بسم الله الرحمن الرحيم. مرحبا بالحضور الكرام. نبدأ السيشن CNS session with the first lecture and updates on WHO classification of adult diffuse glioma. دكتورة دينا السمان.
Okay, good morning, everyone. This is Dina Samain. I will be with you today in the pathology talk on the updates of the WHO classification of adult diffuse glioma. But firstly, before I begin, I would love to express my deepest gratitude actually to my mentor, Professor Manal Mahdi, for nominating me to be with you today. And I know she's not here, but I know she will see this record, that I thank her so much for all her efforts, the support, the provided material, and everything. Okay, and now to begin, let's see for today what are our goals and objectives. Actually, we're aiming at introduction of the CNS WHO 5th edition, the 2021, introduction of the immunohistochemical panel, or all the surrogate markers that can be used for the diagnosis of diffuse gliomas, and introduction of the molecular studies that can be used for further diagnosis and treatment. Okay, and now let me take you through a quick journey, and after all these years and after all these editions of the CNS classifications, finally, the 2016, the 4th edition, revised, introduced to us the term the integrated diagnosis, meaning that we have incorporated the morphology and genetics together to come up with integrated diagnosis. Then came the 2021 classification with all the efforts that the C-Impact done and the publications that served as a precursor for the 5th edition, the 2021 edition, focusing more on all the molecular studies that can be added and incorporated in the diagnosis of CNS tumors. And for now, let's see the general features of the new classification and what they have developed or updated. Firstly, they separated the adult and the diffuse gliomas. This is one thing. They emphasized more the idea of integrated diagnosis as per Harlem 2014. They replaced the term entity with type, and they replaced the term variant with subtype. One more thing, that they replaced the latent numbers of grading with Arab numerals for the grades 1, 2, 3, and 4 within each tumor group. And I'm stressing on this point, this is within each tumor group, because the grading is relevant in a tumor group and not across the different groups. Okay, what else do we have? We no longer use the term anaplastic. Instead, we use the grading system that will be furtherly explained. Now we have essential and desirable criteria for the diagnosis of different CNS tumors that we will see in the coming slides. And finally, they promoted the idea of the methylation profile. Methylation profile is now one of the desirable diagnostic criteria for a number of CNS tumors. Okay. I would love to shed the light on the methylation profiling idea more, and to explain this, we need to know firstly the difference between mutation and epigenetics, okay? Talking about mutation, mutation is the structural changes that occur to the DNA, like a deletion, an insertion, a missense mutation. Structural changes lead to necessarily diseases or different genetic expression. Whereas the epigenetic theory, epi means above. So if I'm saying epigenetic, it's something that happens above the gene, okay? These are non-structural changes, okay? The DNA structure itself is not changed, but the expression is changed, okay? In this demo, as you can see here, are the most common 3 sites for the epigenetics. For example, the DNA methylation, which is what we're going to refer to today as an example for the methylation profiling. One more thing is the histone modification, okay? Includes methylation, phosphorylation, acetylation. And the last thing is the microRNA-based mechanisms, okay? Not to get you so much deeper into details, what I want to say is that epigenetics is like an adjustment knob or something like this, acting as docking sites that regulate the gene expression rather. Okay. And according to Nessa Carey, she had a nice book called the Epigenetic Revolution. She describes that the epigenetic changes primarily occur at specific dinucleotide sites at the CPG islands, where the methyl group attach in these sites and lead to inactivation or silencing of the gene expression. And the DNA methylation patterns were found and were differently expressed in malignancies, autoimmune diseases, infections, and inflammation. Okay. This is one more very good article talking about what they call the DNA methylation-based classification. What's further set now is that they are classifying the different CNS tumors according to their methylation profile. As you can see, for example, in this figure, they are giving the different tumor types codes, shades and codes of colors, color codes, okay? You go for a molecular lab, for example, and you ask, I want to do methylation testing for this tumor. They tell you it is the class for the IDH mutant, for example, glioblastoma. It's the class for the astrocytoma IDH mutant, etc. Okay, again, what I'm promoting to, rather than getting you into deeper details, is that methylation profiling is something that is trendy nowadays, and it's one of the desirable diagnostic criteria in the CNS classification. Okay. Back again to what are the updates or what we are using يعني, as terms nowadays in this classification. Again, we're describing what they call the NOS and the NAC. I will say NOS, or none otherwise specified, when I have a tumor diagnosis with non-available testing. For example, I have a glioblastoma. I'm supposed to do the IDH mutation status or testing. If I don't have the test, I will tell you it's a GBM NOS. If the test is not performed, I will tell you it's NOS. If the test is unsuccessful for any reason, I will tell you it's an NOS. However, if the test is done but it does not fit any of the specific WHO criteria, I will rather describe it as NEC, which is none elsewhere classified. I'm sorry. Okay, and this act should be as an alert for an oncologist that the tumor does not fit actually in any of the probable WHO classification diagnoses. Okay, one more thing that I would love to explain furtherly and focus on is the idea of the integrated and the layered reporting format that we use now for the diagnosis of the different CNS tumors. And by layering, I say that my report should provide the histologic classification of the tumor. This is one thing. The other thing, the histologic grade of the tumor. And the third thing is the molecular information that I can add, okay, and I can test and evaluate, and then incorporate all these data and come to you with an integrated and layered diagnosis. Okay, and now we come to the core of our lecture. Our lecture is going to focus on the diffuse gliomas in adults, okay? And this is how they classified it under the title of gliomas, glioneuronal and neuronal tumors. We have the adult diffuse gliomas, the pediatric gliomas, low grade and high grade. We have the circumscribed astrocytic gliomas, glioneuronal and neuronal tumors, and finally the ependymal tumors. Okay. Another chart for this, diffuse gliomas, as I've just mentioned, include adult type and pediatric type. And the adult type are furtherly simplified into only 3 diagnoses for this edition, okay? We have the astrocytoma IDH mutant, we have the oligodendroglioma IDH mutant and 1p19q co-deleted. We have the GBM IDH mutant, and you can see that the genetic abnormality or the molecular finding, okay, is by definition. So I cannot say anymore oligodendroglioma full stop. It's oligodendroglioma that is IDH mutant and 1p19q co-deleted, okay? And as for the pediatric type tumors, we have the low grade. They are 4 types, and the high grade 4 types. Maybe we can discuss them in a later lecture or talk, okay? To sum up, they summarized or simplified 15 entities which were described separately in the 2016 into only 3 types in the 2021. Okay, and those 3 types that we have, they lasted with us, are furtherly graded. For example, the astrocytoma IDH mutant has the 3 grades, 2, 3, and 4. The oligodendroglioma with the IDH and the 1p19q co-deletion mutations may be grade 2 or 3. And the GBM IDH wild by definition is grade 4. Okay, this is what we've just been saying. Okay, now let's focus furtherly on each and every type and see how are we going to diagnose these, okay? This is the thing that we have just mentioned. To begin with, the astrocytoma IDH mutant, this is how it looks like on cross-sectional images, okay? Okay, this image shows the CT scan with a hypodense homogeneous mass in the right parietal lobe, for example. The other one shows a mass in the parietal lobe that is hypointense on MRI. Okay. Another cross-sectional image for the MRI showing hyperintense mass in the right frontal lobe, and the corresponding FLAIR image shows heterogeneous signal across the lesion T2 FLAIR mismatch. Okay, the last one is for a grade 4. By the way, the first one was for grade 2. The second 2 were for grade 3 IDH mutant astrocytoma. And the last one is for a case that was diagnosed later with a grade 4 IDH mutant, okay? And as you can see, there is a mass with a rim enhancement, the ring enhancing mass, the classic one, surrounding central necrosis. Okay. For me, when I receive the biopsy, how am I gonna diagnose this case? I have essential diagnostic criteria and desirable diagnostic criteria. My essential diagnostic criteria, firstly, is that I have a diffuse infiltrating glioma under the microscope. This is number 1. Number 2 is that I do further IDH testing, okay? And this can be done by immunohistochemistry for the familiar and the popular IDH1 or the IDH2. In practice, we use the IDH1 R132H nowadays, so I find it mutant, then this is okay. The third essential criteria is to do the ATRX testing, and I would be happy if I get an ATRX mutant. And by mutant, we mean that we have loss of nuclear expression. We find the ATRX as negative on our slides. Or we do another test, which is the 1p19q co-deletion, and it is not mutant, it's intact, to exclude that this is a oligodendroglioma and prove that it is an astrocytoma. Further desirable criteria, including the TP53 mutation testing, okay, molecular, or the P53 immunohistochemistry with an expression pattern that is more than 10%, and we call this as a mutant, okay? One more thing, if we do a DNA methylation profile and it is found to be of the astrocytoma IDH mutant, that is so good, and that is keeping with us. Okay, again, the astrocytoma grading, the IDH mutant, I'm talking still about the IDH mutant, grading is for grade 2, 3, and 4. Things are so easy in this way because the grade 2 can be defined when we have well-differentiated picture. Mitotic activity is absent almost or maybe very rarely on big specimens. The grade 3 is diagnosed when we have anaplasia that's starting to appear, mitotic counts appearing in my slides. The grade 4 is diagnosed when I have MVPs, microvascular proliferations, necrosis, and for sure I have extensive anaplasia, a brisk mitosis, and lots of mitosis. If I do testing for the CDK N2A and N2B and I have homozygous mutations or loss of heterozygosity, this supports so much that I have reached the grade 4 anaplastic, IDH mutant astrocytoma. Okay, this is the picture of how things look like in an IDH astrocytoma. Actually, everything is mutant. The IDH is mutant, the ATRX is mutant, and the TP53 is mutant. And it's noteworthy that the word is mutant does not necessarily mean that the tumor is positive. For the IDH mutation, for example, is positive. You can see the brown stain in the slide, whereas the ATRX mutation is negative. You cannot see any or only few non-specific cells in the stain. Okay, all you need from me as data to provide you whether it's mutant or it's wild rather than it's positive or negative. Okay, moving to the next one, the oligodendroglioma. This is the radiology. Okay, we have three sections. So the pre-contrast showing hypo-intense low signal, the post-contrast showing heterogeneous enhancement in post-contrast, and the T2 showing hyper-intense on T2. For me as a pathologist, when I get the biopsy, how am I going to diagnose this? I will look again for the essential criteria. Number one is that I have a diffusely infiltrating glioma. Number two is I'm going to do the IDH testing, and again I find it IDH mutant. Necessarily it should be mutant. And number three, I'm going to do the further testing for the 1p19q co-deletion and find it a combined deletion. Okay, what else desirable criteria that can add and support our diagnosis? The ATRX, and this time I wanted to be retained nuclear staining, meaning it's non-mutant. This is opposite to the astrocytoma. Now I'm saying it's an oligo, not an astro, okay? If I do a DNA methylation profile and it gives me the methylation profile of an oligodendroglioma, and finally, if I do a TERT promoter mutation and it's mutant, again, this is supportive to oligo, okay? Again, the IDH testing, I've just mentioned this, can be done on immunohistochemistry. This is the surrogate marker for the gene mutation. We can test the IDH1, which is mutant in more than 90% of the tumors, or the IDH2. What about the 1p19q co-deletion? They are tested either using other modalities, such as the FISH, the fluorescent in situ hybridization, the PCR, or what they call the array comparative genomic hybridization. Okay, one more thing that I would love to add is that, again, the CDK N2A or B, if there is homozygous deletion, this supports that I'm moving to the grade 3 oligodendroglioma. Of course, besides the presence of MVPs, microvascular proliferations, necrosis, and brisk mitosis. Okay, the key 67, again, all the time is a supporting thing to elevate the grade for sure. This is how the oligo looks like. We have the ATRX, retained nuclear expression, the IDH is positive and mutant. The P53, as you can see, is wild. Okay, this is how it looks like on a FISH. Have to move faster. As for the glioblastoma, the last one that we're going to talk about today, okay, it's a diffuse astrocytic glioma for sure. Essential diagnostic criteria, I have MVPs, I have necrosis, it is IDH wide, I have TERT mutations and EGFR amplifications. If I do the testing for the 7 and 10 chromosome copy number, I find some changes. And if you can do further DNA methylation profile for desirable diagnosis, is a good desirable diagnostic criteria, would support the diagnosis of GBM IDH wide. As to the localization of the GBM, you all know that it comes commonly supratentorial and it loves the frontal lobe, maybe oftenly in the subcortical white matter. Infiltration into the cortex and across the corpus callosum with spread contralateral hemisphere is another thing that is seen. This is how the tumor on immunohistochemistry gives a negative or an IDH wild status. Okay, so this is the immunohistochemical panel that I refer to, that we refer to when we are in front of a glioma, let's say, okay, the GFAP and the S100, the IDH, the P53, the ATRX, and the Ki67, which surely increases with grades. Okay, to sum up, what is the algorithm that we follow when we have a diffuse glioma? Firstly, we think, is it mutant or is it IDH mutant or is it IDH wide? If it's mutant, I go for 1p19q co-deletion together with TERT, okay? If the mutation is there, it is an oligo grade 2 or grade 3. which grade according to the histopathology and the CDKN2A and B if you have the facility to do it. And this is with a good prognosis. Okay, if the 1p19q co-deletion is intact, okay, I'll go for the TP53 and the ATRX. If both are mutant, I will opt for astrocytoma. يعني in the old times they used to say it's an astrocytoma that is maybe grade 2, 3, or 4, but nowadays, okay, we have to, sorry, it's the same thing. We still use the same term as long as we are IDH mutant. It's grade 2, 3, or 4, according what we have mentioned before. The histopathologic criterion, the Ki67 helps us as well, and the CDKN2A and B. Okay, the grade 4, this is what I have just mentioned, the MVPs, necrosis, and the homozygous deletions. Okay, what if we have an IDH wild type? If it's wild type, things are different. We can add the EGFR P10 and CDKN2A to make sure, but we no more يعني describe this one as an astrocytoma. Okay, anciently they used to describe it as astrocytoma. Nowadays it's by definition a GBM, a glioblastoma grade 4, as long as it is IDH wild. Okay, this is for sure obsolete for now. And again, the same thing, I have the MVPs, necrosis, TERT, EGFR, and 710 chromosome copy number changes. Okay, the last thing that I'm going to talk about for today's lecture is a very important, actually, paper, the molecular biomarker testing for diagnosis of diffuse gliomas. Those people, they had summary of recommendations, which are, some are strong and some are conditional. I will focus on the strong one, taking each and every one. When will you, as a neurosurgeon or a neuro-oncologist, order which of which, okay, when you're in doubt? And when do I, as a neuropathologist, should go for? We should go, or it's recommended, yani better say, to do IDH testing in all diffuse gliomas. This is firstly. The ATRX is recommended to be done in IDH mutant diffuse gliomas unless they show a 1p19q co-deletion, okay? You are confident it's an oligo, okay, go for it. You don't have this, do the ATRX to make sure it's not an astro. Okay, you can, 1p19q co-deletion again is recommended, the testing if you have an IDH mutant diffuse glioma, unless they show the ATRX loss or TP53 mutation. If you already have an ATRX loss and TP53 mutation that supports, it's okay, you can ignore it, but if it's feasible to be done, it's better to be done, it's a strong recommendation. The MGMT again is strongly recommended for all GBMs that are wild type. And finally, testing for the chromosome 7p gain and the 10q loss together with the EGFR and the TERT mutations are advisable and strongly recommended for diffuse gliomas that are IDH wild, but they have the histomorphologic features of the doubtful grade 2 or 3. You want to make sure and yani rest peacefully that it's a GBM grade 4, although it's wild, and by definition it's wild, you can support yourself by adding those 3 tests. I'm sorry. Okay. In conclusion, and at the end of our lecture, actually, we had major revisions that are incorporated to the WHO 2021 that we all should be aware of. There's an increasing role of molecular classification and actionable mutations that can be achieved by various testing methods. And finally, the DNA, the trending DNA methylome profiling is really an important breakthrough. Thank you so much. Thank you so much, everyone. شكرا لحضرتك.
شكرا جزيلا دكتورة دينا على المحاضرة.
شكرا دكتور.
تحبوا نسأل لو في سؤال أو حاجة ولا نخلي الأسئلة في
The pathologists are now explaining their lectures with MRI. This is for you, Dr. Khaled. Thank you so much.
ولا يفتى ومالك في المدينة، يعني أنا مكسوفة وأنا بقول الCTs والMRIs. شكرا لحضراتكم.
I have a question.
اتفضل.
According to the WHO 2021 classification, it seems like it's heavily dependent on molecular testing.
Yes.
So my question to you, here in Egypt, do we have all of these tests available
Okay,
or not?
Okay, that's a pretty good question. Unfortunately, we don't have the molecular testing in Egypt, but we have referral labs that send the tissue abroad. Okay, في بعض private labs they send the tissue abroad and you can refer to them. As for the immunohistochemistry لا هو متوفر يعني في ال IDH وال ATRX ال P53 ال BRAF مثلا لو هنعمله لحاجة تانية الحمد لله الحاجات دي موجودة. I hope يعني ان too soon بقى وعلى ايدين دكتورة منال ان شاء الله تجيب لنا المولكيولر تيستينج. The kits maybe او the expensive طبعا. We need a fund for the kits.
Thank you, Dr. Dina.
Thank you so much. My pleasure. Thank you.
Okay, we go to the next lecture. It's a neurosurgery lecture. It is by an eminent neurosurgeon. He introduced stereotactic surgery to the Ain Shams University Department of Neurosurgery years ago. He's an innovator. He has always encouraged us to learn and keep learning and to train to provide better treatment for our patients. And today his lecture is no different. It will be about diffuse low-grade gliomas in eloquent areas, changing concepts in surgical management. He's Professor Ashraf Al-Abyad. Please, sir.
Thank you, Professor Dr. Amr. First, I would like to thank Professor Lubna Zelarab, the President of the Congress, as well as my dear friend and colleague, Professor Khaled Abdelkarim, for their kind invitation. And I'm very happy to be among my colleagues and friends from the Oncology Department at Ain Shams University. My presentation is about diffuse low-grade gliomas in eloquent brain areas. Actually, there have been changing concepts in the management of these lesions, either in the surgical indications and the surgical techniques. As we all know, diffuse low-grade gliomas are very slowly growing infiltrating tumors. They tend to locate within eloquent brain and usually manifest as seizures in young or middle-aged adults who are usually fully functioning. This clinical scenario leads to conflicting decision between observation and intervention, fearing of the potential neurological consequences that might occur due to damage to these eloquent areas during removing of the tumor. The eloquent areas we mean are the supratentorial eloquent areas where these tumors commonly locate in these areas, like the Broca's and Vernix area, language areas, as well as the Roland cortex, where the motor and sensor area lies, and the supplementary motor area in front of them. I'm not sure whether there is a mark. Maybe. This is the language area, inconclusively, and this is the motor and sensor area around the sulcus sulcus and the supplementary motor area in front of them. However, due to the significant advances in knowledge of the natural history and the biology of these diseases, and the increasing use of preoperative neuroimaging modalities and interoperative brain mapping techniques, the management paradigm of diffuse low-grade glioma are evolving from watchful waiting to more aggressive interventional management. Many studies in recent years have been published concerning the natural history and prognosis of these diseases. These studies suggest that these tumors are progressive neoplastic lesions, and over 70% will transform to anaplastic glioma or GBM within a decade. It has been suggested that these tumors passes into 3 stages: the pre-symptomatic stage of unknown duration, the symptomatic period of about 7 years after the initial presentation, and transformational stage of 2 to 3 years of more rapid tumor progression associated with induction of anaplesia. The growth rate of diffuse low-grade glioma is approximately 4 millimeter per year. There is no static diffuse low-grade glioma. Patients with diffuse low-grade gliomas undergoing early maximal safe resection have a survival advantage over those undergoing a biopsy or delayed resection. And the following point is very important, stated by Dufault, one of the eminence in surgery of low-grade glioma, and actually confirmed by many other authors, who stated that even when located in eloquent region, diffuse low-grade glioma rarely present with neurological deficit. The slow tumor expansion allows a plastic reorganization of neural function, which is displaced away from the tumor to adjacent brain. For more explanation, as you can see, this is a functional MRI of the same patient. As you can see on the left-hand side, on your left-hand side, the right-hand motor area is located in the normal anatomical location in the precentral gyrus, what you call the hand knob area, or the epsilon area here. While on your right-hand side, the left-hand motor area is pushed by the tumor far anterior, just behind the coronal suture. But actually, in real life, intraoperatively, this is what we see. There is no, after opening the dura, we see the brain. There is no line of demarcation between the brain and the tumor. And also the distance that should be maintained between the tumor boundaries or borders and the eloquent brain cannot be identified. So, nowadays, there are a large number of techniques that can be used to localize the tumor as well as the eloquent cortex and tracts, either preoperatively by using functional MRI and tractography, or intraoperatively where anatomical localization can be used, can be done by neuronavigation and intraoperative ultrasound, while the functional confirmation can be done by electrophysiological brain mapping technique. But it's important to say all these techniques are not yet reliable enough in lesions involving the language areas, with a complex network of white matter tracts in between. So awake craniotomy is the gold standard technique for surgery in language area. We have operated on 42 patients. The age ranged from 15 to 58 years. Most of them were females. All of the patients presented with epilepsy, and 5 of them presented with additional neurological deficit, either hemiparesis or dysphasia. In the functional MRI, the tumor was located in a periansular lesion, a periansular area, which is the language area, in 45% of patients, while it was located in the peri-Rolandic area, or the motor sensory area, in 55% of patients. The eloquent cortex in functional MRI was zero distance in about 70% of cases from the tumor, and it was less than 1 centimeter in 30% of patients, while the eloquent tracts were pushed or attenuated in 88% of patients, while it was disrupted or infiltrated in 5% of patients. This is the difference between attenuation and disruption. As you can see here, on your left-hand side, the corticospinal tract is just pushed by the tumor in this one, in the coronal and sagittal cut, while it was infiltrated on the other image. The corticospinal tract is infiltrated and disrupted by the tumor. Usually, in most of the diffuse low-grade glioma, which is now the adult diffuse low-grade glioma, we see this picture. As regards the surgical procedure, it's very important, actually, the anesthetic rule. They use what's called TIVA, total intravenous anesthesia. They don't use muscle relaxant to give the chance for intraoperative monitoring. And in 19 patients who had lesion in the language area, we have operated on the patients in awake approach. We use the neuronavigation for planning craniotomy, and we use the intraoperative monitoring. This is the intraoperative monitoring system. As you can see, the first step, we choose the muscles which we are going to stimulate, usually in the contralateral side of the lesion. And we insert subdermal needle electrodes in these muscles, as you can see in the thenar, hypothenar muscle, tibialis anterior, facial muscles, and so on. And we connect these subdermal needle electrodes to the equipment, which actually can generate evoked potential, either somatosensory or motor evoked potential, EEG, EMG, as well as direct cortical and subcortical electrical stimulation. The cortical and subcortical stimulation actually the most important function, and it has different techniques according to the area we are going to stimulate. As you can see here, the probe we use, it's called the Ogemin probe here, and then we see the response of the patient, either increase in the frequency or amplitude of the waves, as you can see on the picture, and sometimes we see limb movement, motor movement, when we stimulate eloquent cortex. This is how we plan craniotomy using the neuronavigation. And if you notice, the patient is not intubated, he is just sedated, and we are going to wake him up after opening the bone flap. We prefer wide craniotomy to avoid brain incarceration into small one, and to give us a room for stimulation of different areas of the brain. And this is the probe we use for stimulation of the cortex. This is how we excite the tumor using the ultrasound, using bipolar and sucker, and trying to preserve the cortical veins, as you see. This is the ultrasound to find the residual of the tumor. Can we lower the? Can we turn the voice down a little bit? And this is the stage of stimulation. It's done at every stage, and you can see here the change in the amplitude of the waves, and sometimes we see motor movement. This is where we do operation under awake craniotomy. We show the patient some pictures for picture naming, counting, calculation, sentence repetition, and so on, handwriting. In fact, there should be a voice here. And then we do stimulation while the patient is communicating with us. Sometimes we meet some drawbacks or complications.
ماشي، ايه دي؟
عربية
لونها ايه؟
أزرق.
ماشي. وده ايه ده؟ ده ايه ده يا صاحب؟
She had speech arrest while we are doing stimulation.
ده ايه ده؟
Our results show that over the 42 patients, 52% underwent gross total resection, which is more than 95%. Actually, no evident tumor in the post-operative MRI. Subtotal resection was achieved in 33.5%, making the whole ratio, I mean, for gross total and subtotal about 88.5%, and only partial resection, which is less than 70% of the tumor in about 15% only. As you can see, the extent of resection is much better in the perinealendic lesion, in the motor and sensory, about 65%, while it was only 37% in the language area, in the temporal area. As regard the immediate postoperative visit, probably surprised you, there was 12 patients who had either new deficit or worsening of their preoperative deficit. So 28% of the patients had worsening of their preoperative status. And actually, this is more evident in those who had preoperative deficit. The ratio is much higher, about 60%. But in 4 weeks only, in 1 month, all patients who had intact function preoperatively, they regained the normal function. And moreover, patients who had preoperative deficit, the 5 patients, 4 of them improved and only 1 patient remained stable, and no one had new deficit after 1 month. This is post-operative, about 3 weeks after the operation, the same patient who had speech arrest, and actually
صلاح وعبد الله وحمادة ومحمود
it
وإسماعيل
took about 2 weeks until she regained her speech.
ونجاة.
ان شاء الله. وسنك كم سنه؟
يعني حركة
This is her follow-up MRI. As you can see, the tumor here very close to the language areas, and this is her post-operative MRI 1 year, showing nearly no tumor. This is a 41-year-old female presented with attacks with speech arrest, grand mal seizures, and as you can see in the functional MRI, the vernix and extra area are 0 distance, while the uncinate and arcuate fasciculi, which are the dorsal and ventral language areas, and the inferior longitudinal fasciculi are infiltrated. Unfortunately, but anyway, the vernix area is posterior to the tumor, the external area is anterior to the tumor, and this is the arcuate fasciculus, and this is the inferior longitudinal fasciculus. This is her 3-year post-operative MRI. The patient received actual radiotherapy, and again, there is minimal residual of the tumor, as you can see. This is a 24-year-old female presented with seizures of 10 years duration with left-sided hemiparesis and hemihypothesia. As you can see, the tumor, the left foot area is and the right and the left hand area is 0 distance from the tumor. This is intraoperative MRI. We do what we call somatosensory evoked potential to identify the central sulcus. And actually, this is the motor area where the probe is located. This is her follow-up MRI, 5 years post-operatively, and showing just area of encephalomalacia. As regard our final outcome, the mean follow-up period was 3.5 years, ranging from 6 years to 8 years. 22 patients were tumor-free. representing 52% of patients. 16 patients had tumor residual under control, and 6 of them received radio or chemotherapy. 2 patients showed tumor progression, and 2 patients showed malignant transformation. This is one of the GLOMI outcome. This lady is 21-year-old lady, gave birth 2 weeks prior to her presentation with generalized seizure of 3 months duration. She developed seizure for the first time during her pregnancy. And as you can see, this is a huge tumor, very close to the motor area, left hand here. And this is 9 months post-operative with adjacent adjuvant radiotherapy, of course, showing some residue of the tumor. But unfortunately, 20 months post-operatively, she presented with gliomatosis cerebri recurrence. In conclusion, the integration of pre- and intraoperative anatomical and functional studies allow for functional tumor resection that significantly widen the extent of resection in diffuse low-grade gliomas. Surgical treatment of diffuse low-grade gliomas has been shown to prolong patient survival, reduce malignant transformation, and improve quality of life as well as seizure control. Thank you very much.
Thank you so much, Professor Ashraf. This fascinating lecture. Do we have any questions?
Radiology and this kind of surgery, after working in the field for more than 25 years right now, and my first footsteps was with your help at the stereotaxy unit at Ain Shams University. I feel that we have been doing great job with the facilities that were in the days, as now the mission is much paved for the younger neurosurgeons, radiologists, and oncologists to deal with those patients to the best of our knowledge and the best of our facilities. When you have shown the tractography, and when I remember when we were dealing with the CT and the very faint MRI open or so, when we are having the H and E pathology and talking right now about those kind of molecular things and these miracles, and the drugs that we having and the facilities in the radiation oncology. Sir, you did a great job. Thank you so much for your time. Thank you.
Now we will move to the next speaker, Dr. Khaled Abdelkarim, Professor of Clinical Oncology, Ain Shams University. Dr. Khaled is one of the first professors who implemented treatment with gamma knife for CNS tumors in Egypt. He will give a talk about stereotactic radiosurgery for low-grade glioma.
Thank you so much, Professor Dr. Lacey, for your presentation. Thanks again for all the audience. Actually, this is not my work. This is a thesis I supervised at Gamma Knife Center. Gamma Knife Center Nasser Institute is not only a private treatment center. We are now an academic center. We supervised more than 20 MD thesis and master protocols at our center. So this was a work from Dr. Ghada Mahmoud from Tanta, and I'm so proud to be part of this team. Dr. Hanan Shawqi, Dr. Said Ali, and Dr. Umniya Abdel Fattah, who were the team from Tanta. This is the outline, and diffuse low-grade gliomas represent a heterogeneous group of primary brain tumor, as we have heard earlier. Median overall survival ranges from 5 to more than 15 years, depending on tumor phenotype, isocitrate dehydrogenase mutation, IDH, and 1p19q co-deletion, tumor size, and imaging growth rate. The prevalence of low-grade glioma is higher in men and white people, and the incidence peaks between 35 and 44 years of age. The management of these tumors, as we clearly have heard earlier, depend on the location. Several studies have described low-grade gliomas as being located preferentially in secondary functional areas. Although ionizing radiation is used in both conventional radiotherapy and radiosurgery, it is the physical conditions indigenous to each technique that make the biological effects of these two methods dramatically different. So, treating high-grade gliomas is much better to be done with fractionated radiotherapy in a linear machines, rather than the single or few doses that can be given to the much low-grade and non-malignant tumors with the gamma knife. Stereotactic radiosurgery disrupts DNA, thus preventing tumor cell reproduction. Radiosurgery uses convergent narrow ionizing beams delivered in a single session or few sessions, as I said, with stereotactic accuracy and precision. The radiobiological effect of such radiation dose on the targeted structure is much more important than that of the same total dose divided into several fractions. Gamma knife was carried out as a primary treatment for tumors in critical location, or as a secondary treatment following partial surgical resection, or to escalate the dose already delivered by radiotherapy with or without previous surgical intervention. This non-randomized clinical study aims at analyzing the efficacy, feasibility, as well as acute and subacute side effects of gamma knife radiosurgery in the treatment of diffuse low-grade astrocytoma patients. This is always a gray zone. The pilocytic or the very low grade is surgery and do nothing, or gamma knife. The higher grade anaplastic or GBM is going for concomitant chemoradio, but this will always be a gray zone for many reasons, especially for the patients who are not accepting the problems that comes after surgery. The non-surgical patients, we should have a solution. 68 patients with diffuse low-grade astrocytoma were treated at Gamma Knife Center, Nasser Institute. All of them were included in this non-randomized clinical study, analyzing the data of the patient treated and followed up until January 2020. Clinical data included age, sex, complaint before treatment, type of surgery, if done, because some of patients, as I told you, didn't accept the risk of surgery, or had not the chance for many reasons to be non-resectable, or can't have anesthesia. The volume, tumor location, diagnosis was done either histopathologically or radiologically with the MR spectroscopy, and the total of those patients included, out of them 3 patients were lost for follow-up. This was our inclusion criteria: residual low-grade astro after surgery, recurrent low-grade after surgery with total or subtotal resection, patients who are not eligible, inaccessible, or refusing surgery, age more than 18, should be more than 18, less than 70, no comorbid conditions, and Karnofsky more or equal to 70. We excluded patients who received prior radiotherapy, and as I told you earlier, pilocytic astro or oligodendro, because different treatment should be implemented. Patients who can't perform MRI for many reasons, like having a pacemaker or so. How we had the outcome measured: by tumor size was determined quantitatively by measuring the tumor at 3 axes, and qualitatively by the degree of deformation of surrounding structure. Tumor volume was calculated by contouring the lesion on each slide. We are having slices 1.5 millimeters, so we can accurately describe our tumor volumetrically. In then matching T2 with T1 weighted contrast images, MRI axial scans by the operating neurosurgeon with assistance of neuroradiologists using the volume function and with the help of our gamma plan system. If the patient's symptoms and signs are stable or improved and no response, if we will call this clinical response. No response if there is progression of the patient's symptoms and signs or appearance of new symptoms or signs. What about the toxicity? It was assessed according to the National Institute of Health and National Cancer Institute common terminology criteria, 4th version. This is our latest Gamma Knife icon model implemented for the last 6 years in NAS Institute. Those are the patient's characteristics. As we can see here, males were more than females, and the age were mostly less than 30, and tumor location were mostly lobar. The timing of Gamma Knife. Gamma Knife came as the primary treatment in 51 patients and as secondary treatment after surgery in 17 patients. Why this comes? Because, as I told you, many patients were not surgical or didn't accept the problems of surgery. And to say it myself before I hear it from the audience, this was one of the weaknesses of our studies about low-grade gliomas, to prove that it is originally low-grade. As many of those patients, we can argue that the cases were not from the A to start low-grade because we depended mainly on imaging. Type of clinical onset, it was almost the symptomatic were 29 and the accidental 39, and the pathological diagnosis was proved in 17 patients. Regarding the image documented tumor response, we had complete remission in 11%, and we have by far the largest portion as partial remission, as you can see, more than half. And here we compared between tumor response and total tumor volume, and definitely smaller tumor fared better. And the dose, the cutoff dose for us was 13 gray, and this was a comparison between the response and the dose, and more stable cases have been in the 13 gray, so we stuck later on to the 11 or 12 grays. Asymptomatic patients at doing Gamma Knife radiosurgery remained asymptomatic after treatment. 23 patients, which is about a third of our patients, were clinically stable. 25, which is about 40% of the cases, clinically improved, and this was to our surprise actually. 7 cases became symptom-free, and neurological deterioration occurred in 10 patients, while 3 of them died after the treatment. Acute toxicity mainly was related to edema, which is part of any radiotherapy treatment to the brain. It was in about half of the cases, and symptomatic edema was in a third of them, reduced appetite in a third of the patient, sleep disturbance in 20% of the cases. The adverse events we saw here, we had 5 patients having cyst post-treatment, hydrocephalus in 5, progression to an aggressive type in 7. The uni and multivariate analysis showed that the type of clinical onset was the main univariate and multivariate significant affection of the progression-free survival. And for factors, again, affecting the progression-free survival, the total tumor volume with the marginal dose, the timing of gamma knife radiosurgery, the number of sessions, all of them affected the progression-free survival. This is Kaplan-Meier curve for progression-free survival to all patients. And to compare patients with less or 9 cc and more than 9 cc volume in respect of the survival. So the smaller volume had better survival. The symptomatic or accidental cases, we can see here the progression-free also demonstrate, according to the clinical onset, those patients had progression-free survival better. The timing of gamma knife radiosurgery and the stage, the progression-free survival, again, to the staged volume treatment. We had adopted this concept for larger tumor. We are not making multi-sessions to the whole volume, but we have staging the volume, part of the tumor to the full dose, and after few months, another part of the full dose to decrease the edema and decrease the side effect. This is now adopted in many international papers. We gathered in many of them. We have been using our data in many international publications. And for the overall survival for the patient, this was the curve. And this is a case of female patient aged 23 years with histopathologically diagnosed low-grade glioma. And for your left side, you can see the lesion on the T2, because on T1, it was not actually seen. And after 12 months, on your right-hand side, you can see the same. We are doing what we call supervised MRI to put the patient at the same posture of the day of treatment. And we do the fusion to know what is treated, what is responding, and what is not of the lesion. Case 2, a male patient aged 35 years with radiologically diagnosed low-grade glioma in left deep parietal region. On your left side, you can see the lesion here. And after 14 months, the lesion is smaller in size, and the edema is also smaller. A female patient, 25 years, with radiologically diagnosed low-grade glioma that located very close to the brainstem, and the images can show you how the difference is and how clinically the patient improved after relieving that pressure from the brainstem. But this was not by all means any thing to replace surgery, because this took months to get the patient in a better shape. The patient will need surgery if surgery is possible, and surgery will remain the mainstay of treatment in such case, compressing the brainstem. So our conclusions, we concluded that gamma knife radiosurgery was a well-tolerated option for diffuse low-grade astro, especially in newly diagnosed patients with sharp borders delineated, defined by imaging. Gamma knife radiosurgery also is an adjuvant to surgical treatment for low-grade glioma. It can be used in this context. Radiosurgery may further reduce risk of toxicity by limiting the volume of normal brain irradiation rather than the usual fractionated radiotherapy. So the risk of neurocognitive or focal deficit has been reduced. It provides durable local tumor control, overall survival, and progression-free survival with acceptable radiation toxicity profile. This would help in preserving the functional performance and the quality of life for the patients with diffuse low-grade astrocytoma, especially for those younger in age. And this is to acknowledge my dream team at Gamma Knife Center Professor Dr. Wael Abdel Halim, Professor Dr. Amr Shahabi, and Professor Dr. Reem Ahmed. And thank you so much. I know I told a lot of information, so if there is anyone awake enough to give me any question, I'm here for it. Thank you so much.
Thank you so much, my dear Professor Dr. Khaled, for your insightful presentation. Upcoming next, may I present my dear colleague, Dr. Muhammad Usama Al-Arabi, Lecturer of Clinical Oncology, Ain Shams University.
So, good afternoon. Thank you, Dr. Hent, for this introduction. Today, we are going to discuss the current and promising treatment options for patients with glioma. So, this is my disclosure. As previously illustrated by Professor Dr. Dina, we know that today diffuse glioma can be classified according to the IDH mutation. For IDH wild type, we consider it as a glioblastoma. For IDH mutant glioma, we should test for 1B19Q deletion. So we have astrocytoma and oligodendroglioma. For glioblastoma, the IDH wild type, for almost 20 to 25 years, the standard treatment for this type of tumors was based on the landmark clinical trial by Professor Roger Stubb. In this trial, patients with glioblastoma were randomized to receive concurrent chemoradiotherapy followed by adjuvant temozolomide versus radiotherapy alone. As we can see that the use of temozolomide with radiotherapy significantly improved overall survival in comparison to radiotherapy alone. Addition of temozolomide increased overall survival by 2.5 months and increased the 2-year survival from 10 to 13%. Also, in a subgroup analysis of this trial, they tried to test the impact of MGMT methylation. We know that methylguanine methyltransferase protein is responsible for the repair and DNA damage, and alkylating agents like temozolomide produce DNA damage. Tumors with methylated MGMT are unable to repair this DNA damage, so they respond more to the temozolomide in comparison to unmethylated MGMT tumors, as we can see in survival curves. For years, we tried to improve the historical STUB protocol. The first trial to improve this protocol was by adding extra temozolomide in the adjuvant setting. So this was a common practice in many oncology institutes, but the GINO 1401 trial, this was a Spanish multicenter randomized trial, randomized patients who completed concurrent chemoradiotherapy followed by adjuvant temozolomide to additional 6 months of temozolomide versus no treatment. And as we can see, the addition of more 6 months didn't improve overall survival or progression-free survival. So there is no value from adding 6 months or extended temozolomide for glioblastoma patients. Also, among of the trials to improve the STUB protocol is the use of tumor treating fields. Tumor treating fields are low intensity alternating electrical fields that disturb mitosis and inhibit tumor growth. The device is portable, non-invasive device. They apply like electrodes on the scalp, and the position of the electrodes is different according to the site of the tumor in every patient. And this technique was tested in the BioVital randomized phase 3 trial, the EF14 trial. This trial used the same standard STUB protocol. Actually, this trial was conducted by Professor Roger Stubb. Then they randomized patients to receive the tumor treating fields with temozolomide for 6 cycles versus temozolomide only. Also in this trial, the addition of tumor treating fields to temozolomide improved median progression-free survival by around 3 months and improved overall survival by 5 months. Another trial to improve the management of glioblastoma came from Germany. In this trial, this is a multi-center German study. They included 141 patients with a newly diagnosed glioblastoma with methylated MGMT, age between 18 to 70, and Karnofsky performance 70 or more. Patients were randomized to receive concurrent chemoradiotherapy with temozolomide followed by 6 cycles of temozolomide, or a combination of temozolomide and lomustine, and the first cycle administered during the radiotherapy. The dual chemotherapy or the combined lomustine temozolomide improved survival in comparison to the use of temozolomide alone. We can see the well separation of the survival curve. Median overall survival in lomustine temozolomide was 40.8 months in comparison to 30.14 months with temozolomide alone. But of course, the addition of lomustine added more toxicity, grade 3 and grade 4 non-hematological toxicities, and grade 3 hematological toxicities with the addition of lomustine. Also, another trial to improve the STAR protocol came from China. This trial was published in JAMA, I think, in 2021. They included 190 patients with newly diagnosed high-grade glioma, glioblastoma grade 4, and astrocytoma grade 3. Patients has good performance status, Karnofsky 60 or more, and age between 18 to 75 years old. And after completing the standard concurrent chemoradiotherapy with temozolomide, patients were randomized to receive interferon plus temozolomide for up to 12 cycles versus temozolomide alone for maximum of 12 cycles. Also, we can see that addition of interferon to temozolomide improved survival in comparison to temozolomide alone. We see that median overall survival in the interferon arm is around 27 months in comparison to 19 months in the temozolomide arm. Regarding progression-free survival, there was no difference in progression-free survival. Also, the addition of interferon to temozolomide improved the overall survival in patients with unmethylated MGMT. There was no survival benefit in patients with methylated MGMT. Also, there was no difference in progression-free survival between temozolomide and temozolomide interferon in patients with methylated and unmethylated MGMT. What about elderly or frail patients? We have multiple trials. The conclusion of these trials that elderly or frail patients can get benefit from the hypofractionated radiotherapy in comparison to the conventional radiotherapy, and this protocol was used in our unit in Ain Shams University like for almost 5 years now. Also, some elderly patients who are unfit for treatment may get benefit from temozolomide alone, especially if they are MGMT methylated. Of course, in glioblastoma, it's common to see pseudoprogression. It occurs in about 30% of patients, and the mechanism of this phenomena mostly is due to increased permeability of the tumor vasculature from irradiation, which is enhanced by temozolomide. And we can see that this phenomena is more in patients with methylated MGMT. For me, the first time to hear the pseudoprogression was from Dr. Khaled Abdelkarim almost 15 years ago. So what's next? Even with the best treatment for glioblastoma, the best surgical management, the best management in radiotherapy or adjuvant chemotherapy, the disease will progress and recurrence will occur. What are our options at the recurrence? We have the conventional chemotherapy, we have temozolomide, temozolomide rechallenge, we have lomustine, carmustine, PCV, and we have targeted therapy. The first targeted therapy for recurrent glioblastoma was the bevacizumab. The beva was compared in a randomized phase 3 trial. The addition of beva to lomustine was compared to lomustine alone, and the addition of beva improved progression-free survival 4.2 months versus 1.5 months, and also improved quality of life in comparison to lomustine alone. But unfortunately, there was no improvement in overall survival. Another agent that used in glioblastoma was the regorafenib. For oncologists, they know regorafenib from the cancer colon. This is an oral multi-tyrosine kinase inhibitor. Dose is 160 milligram for 3 weeks and 1 week rest. In RIGOMA trial, this is a multi-center phase 2 Italian trial. They compared the regorafenib with lomustine for the recurrent or progressive glioblastoma. The use of regorafenib improved the median overall survival 7.4 months versus 5.6 months in comparison to lomustine alone. But of course, we know the toxicity of regorafenib. This protocol is included in the NCCN guidelines, but I think its use is limited due to the toxicity and side effects of regorafenib. What about the immune therapy in brain tumors? We have the Checkmate 143 trial. This trial tested the value of using the PD-1 inhibitor, the nivolumab, versus Beva, 10 milligram per kg every 2 weeks in patients with recurrent or progressive glioblastoma. Unfortunately, the use of immune therapy didn't improve overall survival in comparison to Beva alone. Also, the progression-free survival was actually better with Beva in comparison to the immune therapy, 3.5 months for Beva in comparison to 1.5 months for nivolumab. So today we are in the era of precision medicine. So we have a multiple new targets for rare mutations in oncology and solid tumors. One of the common mutations are the NTRK gene fusions and PRF mutations. NTRK gene fusions is present in about up to 3% of the adult glioma patients, and PRF mutation can be seen in up to 5% of the glioblastoma patients. So we have reports of treatment and improvement of the recurrent or progressive glioblastoma for patients with NTRK gene fusion with the use of larotrectinib and entrectinib, and for the use of PRF mutations like dabrafenib, trametinib, and vemurafenib in patients with PRF mutations. So the NCCN included this as an option for patients with NTRK gene fusion or patients with PRF mutation upon progression. Rapidly, this is the management of patients with IDH1 and 2 mutant glioma. For patients with astrocytoma IDH mutants, grade 2, options of treatment include radiotherapy alone, followed by 6 cycles of adjuvant PCV, or 12 cycles of temozolomide, or observation in selected cases. For astrocytoma IDH mutant, grade 3, we can give 6 weeks of radiation, followed by 12 cycles of adjuvant temozolomide. For patients with astrocytoma IDH mutant, grade 4, they are treated like glioblastoma, IDH wild type. For oligodendroglioma, IDH mutant, and with 1b19q co-deleted and grade 2, our treatment options include radiation therapy followed by PCV or 12 cycles of temozolomide, or observation in selected cases. For oligodendroglioma, IDH mutant with 1b19q co-deletion and grade 3, we can give the PCV for 4 cycles, followed by radiotherapy, or we can give radiotherapy followed by 6 cycles of the PCV or 12 cycles of adjuvant temozolomide based on the trials of RTOG and ERTC. So what is the new in the field of neuro-oncology? What is do we have more treatments? Do we have any drug approval for glioma? The answer is yes. We have the vorasidenib. Vorasidenib was presented in this year ASCO and ESMO conference. It's an oral inhibitor of mutant IDH1 and IDH2. It is specifically designed to increase the brain penetration. It reduces the tumor levels of 2-hydroxyglutarate levels by more than 90% in resected grade 2 and grade 3 non-enhancing diffuse glioma. What happened when we reduce the levels of the 2-HG? This leads to lower tumor cell proliferation and increased tumor infiltrating lymphocytes, leading to more TILDs. So the clinical value of VORA was tested in the INDIGO, a multi-center global phase 3 trial. This trial included 331 patients with who having residual or recurrent histologically confirmed grade 2 oligodendroglioma or astrocytoma, IDH1 or 2 mutation, and good performance status, Karnofsky performance 80 or more, and age was above 12 years. Patients were randomized to receive VORA 40 milligram once daily or to receive placebo until progression. As we can see that the two groups were well balanced. The median age in the VOR group was 40.5 years versus 39 in the placebo. Most patients had a residual tumor above 2 centimeters. Here we can see that the addition of vorasidenib improved progression-free survival markedly. The curve is very well separated. The median progression-free survival is 27.7 months for Vora in comparison to 11.1 months for the placebo. Also, Vora delayed time to the next intervention, not reached in the Vora in comparison to 17.8 months in the placebo. Most common adverse events mainly were hepatic toxicity, increase in the ALT levels, increase in AST, and increase in gamma-glutamyl transferase. Otherwise, treatment with Vora was well tolerated. So my take-home message, molecular classification is now essential for diagnosis of glioma. Radiotherapy plus concurrent temozolomide and 6 cycles of adjuvant temozolomide is a standard of care for glioblastoma. No additional benefit from extended temozolomide in glioblastoma. Observation can be an option for certain patients with low-grade glioma. Vorasidenib is the potential first targeted therapy for low-grade glioma. This drug gained its FDA approval in March this year. Thank you for your attention.
Thank you so much, Dr. Mohammed, for your insightful presentation. Next, Professor Dr. Khadija Tombari, Professor of Pediatric Oncology at Ain Shams University, and her presentation is about pediatric glioma.
Good evening, everybody, and thank you so much for the Thank you so much for the organizing committee and the chairpersons for inviting me to present a brief on pediatric glioma management. Actually, a lot has been said, or mentioned about pediatric adult gliomas and classification and WHO classification. So I will go fast through this. CNS tumors are the most common solid malignancy in children and the second most common malignancy overall after leukemia. Astrocytomas are most common brain tumor overall, mostly low grade. Medulloblastoma are most common malignant brain tumors, and there's a male-female higher prevalence with 1.2 to 1, a ratio of 1.2 to 1. This is an old classification by in the US of the pediatric brain or CNS tumors. And as we can see, medulloblastoma and atypical rhabdoid teratoid tumors, the pilocytic astrocytoma about 4 to 8%. As we mentioned, they are the most common form of CNS tumors, accounting for about 35% of CNS tumors diagnosed in children between birth and 18 years, which is the age group we usually treat. They are either pediatric low-grade gliomas, as previously known as grade 1 or 2, or grade 3 to 4 high-grade gliomas. As you all know, conventional therapies include a combination of neurosurgical intervention, radiotherapy, and chemotherapy with standard chemotherapeutic agents, including vincristine and carboplatin or vinplastin. But the recent clarification, as mentioned by my colleagues, about the molecular background of different gliomas has opened new era in terms of their classification and treatment. This is a brief on the pathway of gliomas. We are talking mainly about the RAS MAPK pathway alteration, including mainly the BRAF, which includes the diffuse low-grade gliomas, KIAA1, FGFR1, which includes the pleomorphic xanthoastrocytoma, pilocytic astrocytoma, high-grade astrocytoma with pyloid features, and the non-RAS MAPK pathway alteration, which is a bit less common, like the MYB gene family, including diffuse astrocytoma and angiocentric glioma, the subependymal with TSC1, subependymal glioma, and choroid glioma. For the high-grade gliomas, mainly the H3 wild type, with all age groups included, which are including the midline, H3 wild type, or the H3K27M mutation, which gives us rise to the diffuse midline glioma, grade 4. Pediatric young adult hemispheric and infant hemispheric glioma, giving rise to the infant type hemispheric glioma, which is a bit different in its prognosis. As you can see, these are the molecular alterations in the different gliomas in pediatric age group. Mainly, I will talk about the BRAF mutation with activation of BRAF kinase domain, leading to pilocytic astrocytoma, and it's used as a diagnostic marker in the treatment. FGFR1 with the upregulation of the RAS MAPIC pathway, and F1, which we see a lot, negative regulator of RAS mutation, MYB, which is an important regulator in the differentiation of hematopoietic and other progenitor cells and commonly detected in leukemia. H3K27 mutation, which decreased the level of lysine methylation, as explained before. And we'll go through. So we'll talk about the pediatric low-grade gliomas. Compared to adult low-grade gliomas, the IDH mutation are less observed in children, and malignant progression is rare, with a 10-year overall survival of over 95%. But the 10-year progression-free survival is about 50%. Surgical resection, whenever feasible, is important for the management of pediatric low-grade glioma, and complete resection is most favorable predictor of survival in patients with this type of malignancy. This is the MAPIC pathway simplified, and through knowing these mutations we will know the targeted therapy we'll talk about later. Usually, the pediatric low-grade gliomas, including pilocytic astrocytoma, is considered a single RAS MAPIC pathway disease. However, some aberrations indirectly affect this. This is a picture from, or an image from a Noonan syndrome patient. The one on the right at the age of 18 months, and the one at the left at the age of 8 years and 9 months. Usually in pediatric, the Noonan syndrome is an autosomal dominant syndrome. It's a rasopathy and related to this pathway, and it's indicated to use growth hormone in such patients, and sometimes it's debatable if this will affect this patient and lead to the progression of such gliomas if they are present. Other alterations we talked about, the MYB and MYBL1 alterations, which are hematopoietic, responsible for hematopoietic differentiation and other progenitor cells that are even present in plants and animals, and they are associated with proto-oncogenic functions in both leukemia and solid tumors. And 10% of pediatric low-grade gliomas harbor this MYB alterations. And they are detected more frequently in young children with a median age of 5 years and often occur in the cerebral hemispheres. CDKN2A homozygous deletion is a gene encoding two tumor suppression genes, the B14ARF and B16I4A, and homozygous deletion of such gene can contribute to uncontrolled tumor cell proliferation and has been reported as a poor prognostic marker in adult gliomas. It's observed in pediatric gliomas and is a hallmark of the pleomorphic xanthoastrocytoma we talked about before. This is an old classification of low-grade gliomas into low risk, intermediate risk, and high risk. And sometimes physicians use this figure to explain to parents the pathology and the molecular genetics and the management, whether it's conservative or proactive or aggressive management, especially with the BRAF B600E. So for low-grade gliomas, total resection, as we mentioned, if there is any role for chemotherapy, like the disease progression or symptomatic patients, this is carboplatin, vincristine, or vinblastine. Radiation as well, however, it's limited in patients with neurofibromatosis and in young infants. Targeted therapy, through knowing the molecular genetics, and I hope that we will have the lab helping in molecular identification of CNS tumors. There is successful treatment with BRAF inhibitors for BRAF mutant gliomas. And the well-known dabrafenib, and not alone, because sometimes single management with dabrafenib, which is can lead to reactivation of the MAPIC pathway. So addition of a MEK inhibitor like trametinib had led to the success of treatment of such patients without the use of chemotherapy. So in September 2023, and then in the New England Journal of Medicine, Buffet et al. Had published this randomized open-label phase 2 trial performed on 110 children with BRAF mutant low-grade glioma when they needed treatment post-surgery. Either they are symptomatic or progressive. So they used post-surgery first-line BRAF MEK inhibitor, dabrafenib plus trametinib, or carboplatinum, the COG protocol of carboplatinum and vincristine, with a comparative overall response of 47% versus 11%, and the median overall progression-free survival in the BRAF MEK inhibitor was 20.1 months versus a progression-free survival of 7.4 months in patients with conventional chemotherapy. Regarding the high-grade glioma, grade 3 or grade 4, they are less common than the low-grade gliomas, and they are increased in patients with previous exposure to radiotherapy or chemotherapy, and in patients with Li-Fraumeni or familial adenomatosis polypi or polyposis with the ABC gene abnormality. The majority of pediatric diffuse midline gliomas harbor mutations at position 27 in H3, F3A, and histone 1H3B-C genes coding histone 3 variants, brainstem position more than 90%, and thalamus 50%, and around 60% in the spinal cord. H3.3 mutation occurs mostly in all midline gliomas, typically affecting children with a median age of 7.4 years and have a very poor outcome, while H3.1 mutation almost exclusively occur in diffuse intrinsic pontine glioma, or what we call diffuse midline glioma, affecting children with a median age of 5.1 years. The best known therapy is maximal safe resection, followed by a combination of focal radiotherapy and chemotherapy, and Dr. Muhammad talked about the temozolomide. Infant, most commonly less than 3-year high-grade glioma, have unique pathology and more indolent course than older children. And as you all know, the diffuse midline glioma presents usually in the classic age of 5 to 7 years, and mostly it has a histone mutation in H3K27M, and complete resection, it's a radiological diagnosis, and biopsy and complete resection is always not feasible. Unlike the low-grade gliomas, there is no much improvement in or progression in the management of high-grade gliomas, and H3K27 inhibitors or inhibition of BRCA2 has not been successful in multiple trials. And some clinical trials of pediatric high-grade glioma have proved no efficacy or safety after phase 1 trial. The last entity we'll talk about is infantile gliomas. It's a very short note about it. Usually, infantile gliomas compared to older children or adult gliomas have a paradoxical clinical behavior. They are classified usually into 3 groups. Group 1 is hemispheric receptor tyrosine kinase-driven gliomas, and they are enriched for high-risk gliomas and have intermediate clinical outcome. Group 2 is hemispheric RAS-MAPIC-driven gliomas, which demonstrate excellent long-term survival with minimal post-surgery clinical intervention. And lastly, Group 3, the midline RAS-MAPIC-driven gliomas, which are enriched for low-grade gliomas, such as pilocytic astrocytomas with BRAF mutations, and have poor outcome in this special age group. I will not go through this. Other therapies that you are not in our center or our country using, including immunotherapy for treating gliomas, like the CAR T therapy, immune virotherapy, vaccine therapy using virus vectors, and circumvention as well of the blood-brain barrier, which is a barrier to the chemotherapy targeting the tumor cells. And there are drug-based using, for example, mannitol, the magnetic resonance guided laser ablation, cranial implantable ultrasound, MR-guided focused ultrasound. So what we moved from pediatric glioma as a rare entity and insufficient evidence with the combination of surgery, chemotherapy, and radiotherapy to precision medicine, as Dr. Muhammad mentioned, and multiple trials on the use of targeted therapy. Thank you so much.
Thank you, Dr. Khadija, for this excellent presentation. Is there any question? Okay, but I mean, based on what we heard today, I think we need to put new guidelines for the management of gliomas based on the WHO classification, the recent one on 21. I mean, before we recognize the diffuse, we can say it adult diffuse low-grade glioma with the special radiological characteristics, as we all know, and sometimes we don't take a biopsy and we refer it for radiotherapy or gamma knife without even taking a biopsy. But you know, based on this new classification, this means that this low-grade glioma or grade 2 glioma might be IDH wild type. Is that right? Radiologically, I mean, are we able now to classify radiologically these new, classifications? And grade 3 might be IDH mutant. Is that right? So, I mean, do we have to rely on pathology and biological markers, or still we can rely on the radiology for diagnosis? لا يعني لحد دلوقتي يا دكتور خالد في بعض حالات اللو جريد جلايوما.
احنا في ايرا داخله التارجتد ثيرابي، والتارجتد ثيرابي is very expensive treatment and has its own profile of toxicity. فمش صعب قوي ان انا هريلاي التريتمنت ديسيجن في دواء معتمد على الماركر، على يعني انا ممكن اعتمد على ان انا ادي راديشن، لكن ان انا هدي دواء هيتكلف الاف الدولارات بير بيرسون لفتره مفتوحه في غايه، يعني غالبيه التارجت ثيرابي بتتاخد انتل بروجريشن على الراديولوجي فقط. انا اسف اني برد عن خالد، بس خالد بيه هيوضح وجهه نظره. انا من وجهه نظري انه القرار بتاع الانيشيشن اوف تارجتد ثيرابي it should be based on molecular on pathological. اتفضل يا بيه.
انا موافق جدا، بس هي الفكره ان في many cases up till now بنdiagnose الديفيوز لو جريد جلايوما بيزد على الام ار اي ويمكن الام ار اس، ونقول دي ديفيوز لو جريد جلايوما ميوتنت، حتى بنجيبها في السبكتروسكوبي، واحيانا بيتعمل فيرذر مانجمنت بناء على كده، بناء على راديولوجي بس.
هو الحقيقه انا كنت حابب من الاول، ويمكن انا في MDT ميتنج مع اسم النيورو سيرجي اتكلمت في الكلام ده. وي هاف تو ستاندردايز ذا تكنيك. يعني احنا عندنا كل الفاسيلتيز دي من زمان قوي. يمكن يعني لو انا هتكلم على الدمرداش مثلا، احنا من 2011 واحنا عندنا برفيوجن، سبكتروسكوبي، تراكتوجرافي، فانكشنال ام ار اي، الكلام ده كله افيلبل. لكن ان انا اعمل كومبريهنسيف نيورو اكزام واستخدم كل التولز اللي عندي في الاول علشان تكملوا انتوا الطريق بعد كده، ده ما كانش بيحصل. ايفن دلوقتي كمان بقى في بعض التغييرات في البروتوكولات، ان انا ممكن استخدم ال 3DT1 علشان اخد 1 ملم adjacent cuts عشان الراديو ستيريوتاكتيك راديو سيرجري، ان انا احقن بعد، وده بري كونتراست وبوست كونتراست، وان انا اخد ال 3D فلير برضو علشان اعمل مور كاركترايزيشن للماسز اللي احنا بنشوفها. We have to standardize the technique. الحقيقه اللي سبقونا في القصه دي وعملوها على مستوى الجامعات وعلى مستوى مصر المالتيبل سكليروزس مع اسم النيورولوجي، هم فعلا دلوقتي عملوا ستاندردايزيشن للتكنيك بتاع التصوير وستاندردايزيشن ايفن للريبورتنج، عشان يعرف برضو يصرف برضو الادويه اللي هي برضو بملايين. فالحقيقه احنا محتاجين برضو ان احنا تستاندردايز الايمجنج، ان انا مبدئيا لازم اصور على هاي فيلد MRI 1.5 3 تسلا، لازم اعمل الكومبريهنسيف نيورو اكزام عشان اعرف اعمل كاركترايزيشن كويس واقدر اعمل فولو اب. يفضل طبعا ان الفحص يتعمل في نفس السنتر طول الوقت كانيشيال ستادي وفولو اب بعد كده عشان الكومباريزون وتو جين اكسبيرينس. احنا الحقيقه حتى، وده السبب اللي انا كنت طالع على اساسه اسم نيورو سيرجري في الMDT ميتنج، انا محتاج ادرب الاطباء الجداد على استخدام التكنيكس اللي هي متاحه، لكن قله عدد الفحوصات اللي بتتعمل مش مخليه الناس تتمرن عليها to get a good training و get good interpretation للداتا اللي بتطلع، وتimplement الداتا ديت في الدايجنوزس وتشارك في الايرا بتاعه الادويه الجديده والمانجمنت الجديد، عشان نطلع سواء كان سيرجيكال او ميديكال عشان نطلع بنتيجه ايه افضل ما يكون للعيان. فهي دي المسج بتاعتي الحقيقه في
استاذنك دكتور خالد، الحالات اللي هي اتعمل لها راديو سيرجري في اللي هي ديفيوز لو جريد جلايوما، هل كلهم باثولوجيكال دياجنوست ولا معظمهم راديولوجيكال دياجنوست؟ ما هي دي النقطة اللي أنا بتكلم فيها. الحاجة الثانية is there يعني limited volume for radio surgery أو جاما نايف في الحالات دي؟ ولا ممكن تدي كذا سيشن لليجن كبير؟ اتفضل. تمام، شكرا.
هو في آخر نقطة بس عايز أقولها، موضوع ال WHO Classification 2021 حطينا برضو إحنا السيرجنز في مشكلة، إن هو إحنا كنا بنعتمد إن diffuse gliomas دي mostly benign، أو دلوقتي لا، الموضوع اختلف، ده في aggressive types. ده هيفرق معانا إحنا في السيرجري، إحنا بناخد decision للراديكاليتي بتاع السيرجري بناء على radiological appearance. يعني أنا لو عندي تيومر في الاليكوينت اريا وهو عارف ان هو او متوقع ان هو بناين، انا مش هبقى فيري اجريسيف في الريسكشن بتاعه على اساس على حساب الاليكوينس. انما لو انا عارف من الاول بس ان ده اجريسيف تيومر، فانا في الحاله دي بعكس، يعني بحط السرفايفل بتاع البيشنت هيد اوف الاليكوينس. فانا ما اعرفش ايه حل المشكله دي. لو في حاجات زي ما كان زمان في حاجات زي الفروزن سكشن، حاجه سريعه تقول لنا الباثولوجي ده ماشي في انهي اتجاه، هيفرق معانا.
انا كنت حابب اسال الدكتور خالد، هل احنا عندنا راديولوجيكال كرايتيريا معينه اقدر اعرف منها التيومر مثلا MGMT ميثايليتد unmethylated IDH1 ميوتنت، هل او ممكن بعد كده بعد فتره نعتمد على بقى بما اننا في الايرا بتاعت AI ان انا ادرب الماشين ليرنينج واعمل ان انا بعد كده اقدر اعرف ان التيومر ده راديولوجيكال كرايتيريا؟
هو احنا في الوقت الحالي، يعني احنا كان جاي لنا قبل كده برنامج كان جاي من اليابان اسمه كيس ماتش، كان هم عندهم اكتر داتا بيز لاكتر من 2000 سي تي تشيست لبالمونري تيومرز، والتيومرز دي كلها اتاخد منها بايوبسي وبقت معروفه هي ايه. فالبرنامج كانت الفكره بتاعته كلها ان انا كل سي تي تشيست فيه ماس اروح اعرضها على الداتا بيز اللي فيها ال 2000 تيومر بالايمجنج كاركترستيك بتاعته، وطالع هيستوباثولوجي فيقول لي دوت غالبا هيطلع كذا. ده بس ده كان قبل الايرا بتاعت يعني ده الكلام ده كان مثلا من 10 12 سنه في اليابان يعني. وطبعا احنا كنا ناويين نشتغل الشغل ده في عين شمس على الاتش سي سي، لكن الموضوع خد مجهود ضخم جدا وما كانتش الناس يعني انترستد قوي في القصه، فما مشيش الموضوع. حاليا احنا لسه بادئين بروجكت للارتفيشال انتليجنس ان انا اقدر احسب التيومرز فوليومتريك، سواء كانت برين، يعني في 2 جروبس دلوقتي هيشتغلوا مع بايوميديكال انجينير بيديفلوب السوفت وير على الابدومينال تيومرز عموما وعلى البرين تيومرز، ان انا اقدر احسب الفوليومتري واقدر اعمل كومباريزون، اوتوماتيك كومباريزون ما بين البري والبوست. انا اقدر بالفيدباك بتاع الموليكيولر ايمجنج، ان انا اضيفه واعمل حاجه زي الكيس ماتش كده، ان انا ده التيومر ده بالكاركترز ديت اللي كانت في الايمجنج في الديفرنت سيكونسز في الام ار اي كانت الكاركترز بتاعتها كذا، فدوت لما عملنا وطلع كذا، فاقدر بالديب ليرنينج بعد شويه وان انا اكبر الداتا بيس بتاعتي ان انا اقدر في الاخر اخلي الاي اي يقول لي ده غالبا هيطلع كذا. ايوه ده احنا دخلنا في الايرا دي دلوقتي، لكن احنا محتاجين ان احنا يبقى عندنا الداتا بيز بروفد عندنا، وده برضو الكولابوريشن اللي انا كنت عايز اعمله مع اسم النيورو سيرجري. انا عايز انيشال ستادي للعيان تتعمل بالكاركتر ببروتوكول وسيكونسز معين، اقدر اخليه في الداتا بيز في الفايل بتاعت العيان، وابني على الكلام دوت الفولو ابس بتاعته سواء بوست سيرجيكال او بوست تريتمنت، واخد الفيدباك من اسم الباثولوجي، فاقدر اضيف الكلام ده في الالكترونيك ميديكال ريكورد بتاع المريض، واقدر اوصل في الاخر ان انا بيلد ماي اكسبيرينس، انا عندي ايه، انا شكل الاورام بتطلع عندي شكلها ازاي في بلدنا عموما، انا اقدر اوصل لهذه المعلومه. It will take time but we have to start.
طيب في البداية أنا عايزة أشكر حضراتكم. كنت عايزة أأكد يعني على التساؤل اللي كان دكتور أشرف بيقوله، إن فعلا أنا عندي في الباثولوجي if I have the features of a grade 2 or a grade 3 by histomorphology وعملت ال IDH immunohistochemistry وطلع wild، أنا هرجع خطوة لورا هقول it is a GBM grade 4. الاميونو هينططني في الجريد. this is true يعني حضرتك. دي حاجة. الحاجة التانية هو الحقيقة الادفانسز مع عدم وجود بقى المولكيولر فعلا in practice هو كمان مكتف. يعني انا مثلا كنت عايزه اسال حضراتكم سؤال. جالي مثلا حاله ستيريوتاكتيك بايوبسي، عملنا لها الاي دي اتش طلع ميوتنت، عملنا لها البي 53 طلع وايلد تايب، ما كانش عندي 1 بي 19 كيو كوديليشن، شويه فوكاليتيز توحي انها اوليجو. دلوقتي انا ما اقدرش اقول اوليجو كده مع نفسي، فاضطريت ان انا هنساين اوت الحاله دي as diffuse infiltrating glioma IDH mutant favoring oligo، ونوت تحت انه احنا we are recommending ان حضراتكم بقى تعملوا ال ATRX وال 1P19Q co-deletion والكلام ده. سؤالي بقى، هل حضراتكم you proceed for this ولا حضرتك هتمسك في كلمة الأوليجو and you will يعني manage the case as if it's an oligo؟ هل هو أساسا on the surgical and on oncological level في فرق في المانجمنت ما بين if it's an astrocytoma IDH mutant or an oligodendroglioma؟ يعني هل أنا ساعدت حضرتك ولا احنا الاتنين دلوقتي واقفين في مأزق because we are short in molecular؟ شكرا.
We are always في مأزق الحقيقة، لأنه لما بوصل للنقطة دي definitely treatment اوليجو غير treatment استرو، بس لما نوصل للنقطة دي أنا غصب عني لازم أفكر في المور aggressive treatment، لأني ما عنديش الشانس إن أنا أكمل زي ما حضراتكم جميعا كده اتفقنا إن أنا أكمل على الموليكولر ليفل بالنكست سيكونس جينيتك أناليسيس، وأقدر أقول إن ده مش هيوافق إلا الكاتيجوري الفلانية. والأفظع من كده إن أنا لو عملتها وتأكدت قد لا يكون الدواء متاح. فانا لازم اتعامل على الاقل في الفتره دي لحد ما نجين النولج دي على اساس المور اجريسيف تيومر والمور اجريسيف بيهيفير ان ذا speculated diagnosis، على اساس ده المتاح عندي، سواء متاح دواء سواء متاح لاين اوف مانجمنت. والا لو انا خدت قرار يعني اتشبث انها لو جريد مش اوليجو، يبقى اعالجه على انه لو جريد ويجي يحصل الريكرنس كاوليجو، هتبقى قراري مش مظبوط لانه دي الداتا الموجوده. لو انا عندي لو انا في البيست سيناريو وانا عايش في يعني احسن بارادايس، اعمل كل حاجه في الدنيا لانه ده هيسمح لي استخدم الادويه الجديده اللي معتمده على الجين مابينج. ثانك يو سو ماتش. انا اسف جدا اني خدت من وقت حضراتكم واخرتكم، بس ممكن تاذنوا لي مع الاساتذه اللي ادوا المحاضرات ان احنا ناخد جروب فوتو بعد اذنكم. اكون شاكر لحضراتكم، شكرا جزيلا.